Hello, my name is Ian McCall, and this is a consultation in dermatology. We're going to talk today about the persistent invaders, warts, or the papillomavirus. Now, there's not one papillomavirus, there's a whole series of what are called serotypes. In fact, I think there's more than 100 now have been identified. And the basic problem is that to be immune to all of these, you essentially have to develop 100 different types of immunity, because they all require a different immune reaction to knock them out. You get rid of a wart virus when you develop an immune reaction to it. It's the same way that you get over mumps, measles, chickenpox, and anything else. You don't get over it until you do develop an immune reaction. And there are some individuals who have great difficulty in developing immune reactions. For instance, people who have atopic dermatitis have difficulty developing immune reactions to the papillomavirus, and their warts will last a lot longer. And obviously people who have AIDS, people who are on steroids, people who are on immunosuppressive drugs, they're all going to be susceptible. And certainly, you know, the transplant patients, they want to get their warts cleared before they have their transplant, because it's almost impossible to clear them once they're on immunosuppressive drugs. So persistence of warts is all about mounting a proper immune reaction to them, or the lack of it. There's a whole variety, as I say, of these wart virus, and they have different presentations, but there's, I suppose, just a limited number of ways in which the wart virus will present, but different serotypes have certain presentations. Now, we've said they're warts or viruses, papillomaviruses. They replicate in skin cells. They don't travel through the bloodstream. They replicate in the keratinocytes. And if you inoculate the papillomavirus into someone's skin, it takes about a couple of months before the virus really starts to replicate. It moves its way up in the cells from the basal layer up to the epidermis, and then gradually it sort of expresses itself there. It can take even longer in some people. The virus can sit there for a while before it really shows itself. Not only do they involve the keratinocytes, they'll also involve mucosal surfaces, so particularly gentle epithelium, the inside of the mouth. And the problem is some of these viruses actually have the ability to cause squamous cell carcinoma. They're called oncogenic papillomaviruses. And these are particularly ones that occur on the gentle epithelium. But the majority are not oncogenic, and they're in fact harmless. So what serotypes do we know? Well, the common Verrucae vulgaris, you know, the one that we commonly see, it's usually HPV types 1, 2, 3, and 4. These genital mucosal types tend to be 6, 11, 16, and 18, and some of those are certainly oncogenic. And then there's another condition called epidermal dysplasia verruciformis. Now that's a curious type of papillomavirus infection where you've got massive amount of warts over the body surface. And they can either be massive numbers of what are called plain warts, and we'll show you those in a minute, or flat warts. Or they can look like a condition called pityriasis versicolor, which is really a yeast infection, but it's very flat, finely scaled. But they involve large surface areas, and these are seen in individuals who just have an incapacity to form a proper immune reaction. And the types that do that are types 5 and 8. And unfortunately, in these individuals, some of these types can go on and form squamous cell skin cancers, and that's the big issue in patients who have this epidermal dysplasia verruciformis. So the wart virus is a DNA virus. And this is a picture of the capsid here. Let's start having a little look at some of these pictures. This is the spherical nature of the wart virus. These are the little capsids that form part of the outer wall of the virus itself. This is an electron micrograph. And what happens is when the papillomavirus is in the keratinocyte, it inserts certain viral markers on the outside of the keratinocyte, on the outside of the skin cell. And it's those viral markers that the immune cells in the blood have to recognize to be able to mount an immune response. And it's a fact that the younger a wart is, the more of these viral markers are in the outside of the keratinocyte. The older it is, the less viral markers are there, so the more difficult it is for the immune cells in the blood to recognize that there's virus there. There's a good section in Wikipedia on the papillomavirus, and I'd recommend that you have a little look there. But let's have a look at some clinicals. I mean, there's your common wart, but it's in a terribly difficult area in the periungual area. It normally just pushes down into the skin. It doesn't invade into the tissue underneath. So generally, the nail itself is intact. It's not damaging the nail matrix under there. But this is an exquisitely painful area. If you're going in after this with liquid nitrogen or other treatments, it's very painful to try and treat here. There you can see the real keratinous site. There's a big epidermal keratin response on the surface, so they're protected by this layer of keratin, and the virus particles are underneath this. So when you're putting things on these to try and treat them, you've got to really get rid of that keratin first for it to penetrate properly and do anything. Let's have a look at some others. There's someone with multiple warts. Look at this was the other hand of the patient you've just seen there just now. And look at the spread of these warts elsewhere. Obviously, a major cosmetic problem. People don't like having this. People, are very self-conscious about having these wart viruses. And if they work in the public area, it's obviously very, very problematical. They can spread the virus. If they pick at these, then they're liable to get the virus coming under their nails, so it's important to get children not to pick at them. But then, miraculously, same patient, they've had an immune reaction, and all that has gone. All the virus has gone, the wart virus is gone, no scarring, no marks. And this is important. If you have a proper immune reaction, things go back to normal. If you've gone in there early and tried like blazes to burn these out, laser them out, or what have you, then you're liable to have damaged the nail matrix underneath, and you may well get deformed nails, you may well get permanent scarring there. So the great virtue of time is that if they get an immune reaction, the warts will completely disappear. Look at the problem with the warts that this patient has. This patient had a condition called Noonan's syndrome. For those of you who are medically qualified, it's a sort of male equivalent of Turner syndrome. And they do have some immune deficits, and he had a terrible propensity to develop warts. You can see the extent of the palmar involvement. All of these are warts. And where there's ever an immune problem, be it AIDS, be it some congenital thing, then the wart virus can proliferate tremendously because they will only go if you develop an immune reaction to them. There's your typical plantar wart. Here the pressure makes the wart grow in the way rather than out the way, but it's still a pushing action that it has. If you look at the histology of this, you'll find that it's still in the epidermis itself. It's not breaking through and invading into the dermis. It's purely an epidermal thing. So you can almost shell it out. But the problem is that even if you go in there and try and shell that out, there's actually wart virus out here in that skin that looks normal. If you examine the DNA of these cells out here that look normal, you'll find that there's wart virus up to sometimes about 5 millimeters around the wart. So that's one of the reasons why if you're just cutting here or burning this out, you might well get recurrence. And the big problem about the foot is if you burn right through into the dermis and into the fat layer trying to cut these out, you're liable to get scarring, and it's like walking with a stone in the sole of your foot for the rest of your life. So you don't want to do that either. You want to try and get an immune reaction occurring. Let's have a look at some others. That's what happens, by the way, if an immune reaction does occur. All the little capillaries that you see in a wart, if you pare it back, you'll see tiny little bleeding points, and that's the vascular supply to the wart. And when a wart involutes, what happens is that these little vessels all thrombose, and this will go black, and it'll fall out, and the skin will heal up normally. And that's really what you want to see at any stage. There's a couple of other pictures here. I thought there would be a bit bigger than that. We'll go back. Bear with me while we try and come to that particular picture. Here you can see a very extensive wart here, and this is it on the sole of the foot and the undersurface. This was in a diabetic patient who was on steroids, and the wart virus proliferated tremendously. And sometimes when you get a wart like this that seems to be growing for a long time and it's very exophytic like this, it may be a condition called epithelioma cuniculatum. And that's a curious type of oncogenic wart virus that will slowly spread and can occupy the whole of the sole of the foot. It doesn't spread elsewhere. Histologically, it looks a little bit like a squamous cell skin cancer, but it's a very well differentiated one that doesn't metastasize. That's a bigger picture of this. You can see how extensive the wart virus is in this particular patient. Now, we did tackle this patient because of the smell and because of the problems he was having. We did tackle it by curetting it. In a diabetic, I agree you have to watch, but he didn't have a neuropathy and the circulation was okay. And he actually healed up quite well there. We reduced the mass of the wart. We did not induce an immune reaction. He did not get rid of that. And over 2 to 3 years, some of it grew back and we had to go back again. So physically trying to burn things out with lasers or curette them out like this isn't necessarily going to get rid of it. These are plain warts or flat warts, P-L-A-N-E, flat warts. This one is a little bit more filiform. And often if you have the same virus up on the edge of a mucosa here, although it's likely to be a different serotype, then you can get a true filiform wart that has a very thin stalk and is cauliflower-like and comes out from the lip. As I said, they are a different serotype. Similarly, this is another wart in the scrotal, well, in the groin fold of this particular patient. You can see how exophytic these ones are. In these areas, they're not as, there's not as much keratin on the surface. So you can put topical preparations on these that will penetrate quite well and quite easily and can, in fact, induce a cytotoxic reaction and perhaps an immune reaction. And he was treated with some podophyllatoxin. Podophyllin is a cell spindle poison, and it can have a necrotic effect on these, and that can induce the immune reaction. And that's actually what occurred with him, and they disappeared completely to leave this sort of picture here. This is what's called a donut wart. This is where there's been a wart here. It's been frozen hard in the middle. There's been a blister. And you've got rid of the central part, but viral particles have gone into the side wall of the blister in the fluid, and they've deposited along the outside of the blister, and subsequently it forms this donut shape when it recurs. So freezing, all freezing does is, warts can survive minus 150 degrees centigrade, so they can almost survive in liquid nitrogen, indefinitely. So trying to freeze them for 20 seconds doesn't do a lot, but what it does is it makes them more vascular, it increases the local blood supply, and hopefully the immune cells in the blood recognize the papillomavirus is there and mount an immune reaction to it and get rid of it. That's really what you're trying to do by repeatedly freezing warts. It also means that your topical preparations, if you're going to treat them, like your podophyllin or your salicylic acid or lactic acid type wart paints, can penetrate more easily after it's been frozen. Here's a difficult one when you get one that's occurring on a mucosal junction like this, and the issue is that a wart or is it an SCC? And it can be very difficult, squamous cell skin cancer, it can be very difficult to tell, and you often have to actually biopsy and biopsy deep so that the pathologist can see. In warts, there are, in the histology, you'll see actual viral particles coming up as blue granules in some of the keratinocytes high up in the epidermis. And the pathologist can make that diagnosis. That, by the way, is the histology of a wart. You can see the pushing edge of it here. There is certainly epidermal hyperplasia, and it might be misdiagnosed as a well-differentiated SCC. But you need a high-power view here to see some of these viral particles in the cells up in this area. But you can see the pushing nature of it. If you can get underneath this, you appear to get rid of it. But remember I said, if you check the skin further out here with DNA probes, you'll find that there's viral DNA up to 5 millimeters around one of these lesions. So you've got to do a lot of cutting to actually get it out. And sometimes you can get genital warts that appear like this, brown and flat, almost like seborrheic keratoses. And these can go by the name of boinoid papulosis, because when you do histology in these, they look like well-differentiated SCCs. And we said before that you've got oncogenic, especially I think type 11, type 16, are oncogenic papillomaviruses that can ultimately develop into squamous cell skin cancers. Now, if we're going back to aspects of treatment, and I think let's go back to this particular thing here. How are you going to treat these? You can freeze them, but that's going to be very painful in that area, and you have to freeze them repeatedly. Even if you just freeze some of them, even if you just freeze these ones up here, if they develop an immune reaction to these will in fact all go. You can use wart paints. Most wart paints have salicylic acid or lactic acid in them. There's one called Durafilm that you can buy that has these components in collodion. You have to trim away or rub away the keratin there so that the paint can be applied. I don't think occlusion really makes a lot of difference there, but these sort of preparations can be bought and can be used. There's podophyllitoxin we talked about. That's best for those perianal and the thin non-keratotic type wart because it penetrates better into them. For plain warts on the surface of the face, if we can show you that case again, often what you use there is retin-A cream or adapalene, something that causes a bit of irritation here, again to try and induce an immune reaction, and they'll go. But you don't want to do anything that's too aggressive. You don't want to freeze hard here where you may in fact damage the pigment cells and be left with permanent white marks if you try and freeze these too hard. You shouldn't use podophyllitoxin on anything near the mouth either. It's certainly not recommended. Regarding other therapies, say for plantar warts, where was that plantar wart? This one here. You can trim all this off, just take away that thick layer of keratin. You can put a little hole with elastoplast around here, and then you can put a paste on called Upton's paste, which contains 10% trichloroacetic acid, about 60% salicylic acid, made into a paste with glycerin. And a bit of that's put on, and another piece of elastoplast put it on the top, and it's left there for about 4 or 5 days. This will soften a whole lot of the tissue here, and you can then scrape it and cut it away quite easily just with a 15 blade. And if you keep at it like that, you know, leaving it on for 3 to 5 days, trimming, giving them a few days break, doing it again, then you can certainly get into these, reduce a lot of the mass of the wart down, make it more comfortable to walk on, and ultimately they can get an immune reaction. You can combine that with a bit of freezing in between as well. It's a case of keeping at warts to try and get rid of them. There's no easy way of doing it. There was a fashion there for prescribing a drug called cimetidine, which is an H2 blocker, usually used for stomach acid, for stomach ulcers. And ranitidine is another alternative that's available. And there was some evidence that in children it seemed to have some immunomodulating effect and stimulate an immune reaction. But I think most people nowadays feel that it's really no better than placebo in time. But at least gives you something to buy that bit of time. You know an immune reaction is going to develop at some stage unless that patient's immunosuppressed. And often I think a lot of our treatments just buy a bit of time until that immune reaction occurs. And whatever happened to be used when the lesion goes gets the benefit for getting rid of the wart. I think that's why there's so many cures as such out there. In terms of any systemic therapy, there aren't really any systemic drugs that will work. Occasionally, oral retinoids like neotigacin can be used in someone who's got severe generalized warts. That's on the hands and feet. That seems to change the local skin in a way that it makes it easier for an immune reaction to occur. So I occasionally use oral retinoids. You can only use those in males because they're teratogenic in females. And in epidermal dysplasia verruciformis, that generalized form of wart virus, you've got to keep the patient out of the sun, because the sun plus the wart virus can certainly make it more likely to turn oncogenic and cause squamous cell skin cancers. The big advance in wart therapy has been this: a vaccine called Gardasil. And note that it's only for type 6, 11, 16, and 18. These are the main oncogenic type of wart virus that we talked about earlier on. And essentially, this is the same virus that causes cervical cancer in girls. And of course, it can cause penile cancer in males as well. So this vaccine was introduced to try and immunize young ladies before they get exposed to the papillomavirus through sexual contact, to immunize them against these viruses so that they wouldn't go on and develop cervical cancer. And it's been one of the great success stories in the management of papillomavirus. Ian Fraser, a fellow Scotsman, but he's been working in Australia for a long time, was, along with his Chinese colleague who subsequently died, were the people who put this, made this vaccine what it is, really put the theoretical work together and took it to practical completion as well. And nowadays, this is given to all youngsters in their, I think, early teens at school. And it's now recommended that it should be used in boys as well, that they should be vaccinated to try and stop penile cancer occurring. And some of my colleagues have in fact been using it for people who have recalcitrant warts. Now, it's only going to work if their warts that they have elsewhere have one of those serotypes. And it's very difficult to serotype warts. It can be done in for experimental and research purposes, but I don't think it's easily available in Australia yet. I think in the States you can get your wart serotyped at labs, but it's quite expensive. But I think variations on this vaccine, perhaps with different serotypes, are what's going to be used in the future for prophylaxis for the wart virus, and it may in fact have treatment possibilities in some people who have depressed immune systems, such that it may help them to develop an immune reaction to get rid of their warts. So Gardasil and perhaps other vaccination methods are going to be the way that we're going to get rid of the wart virus in the future. So an exciting area, a difficult area for treatment. Time is always on the doctor's side. It's just a question of doing non-scarring treatments. Don't do things that are going to cause scarring, because scars are going to stay forever. And you want to basically just try and get that immune reaction to occur to get rid of this tiny, tiny little virus that has caused so much trouble. One last thing. The papillomavirus is seen throughout various animals as well as humans, but it's species specific. In other words, dogs can get papillomavirus, but their virus won't transmit to humans, and human papillomavirus won't transmit to dogs. So the papillomavirus has been around for a long time. It can change. The fact there's 100 serotypes indicate it can genetically change to meet the circumstances in which it finds itself. And it's very difficult to get a vaccine that's going to have 100 serotypes in it to be able to vaccinate against everything. So I suspect this little virus will be around for a long time yet. And I also suspect that we don't know everything about this virus yet. It may well be involved as a co-carcinogen in other tumors that are in the body. And certainly, even with, say, laryngeal cancer, it may well be involved there. And perhaps the Gardasil vaccine would have a place there as well. And I'm sure there's other conditions that I don't know about that this little virus is involved. So papillomavirus, dermatologists have a lot of respect for it, and I hope you've learned a little bit more about it from this video. Thank you very much.